Morning everyone. My today's topic is pediatric endodontic material. These are contents of my topic: introduction, definition, different operating materials, recent advances, conclusion, and the final of endodontic treatment is to fill the entire root canal system and in all its complex anatomic pathways completely and closely with non-irritating hermetic sealing agent. Obturation of root canal should result in complete seal from the coronal aspect to apex, preventing the entry of microorganisms and fluids. 1995 defined as the complete removal of necrotic pulp uh, from the root canal of primary teeth and filling them with the inert restorable material so as to maintain the tooth in the dental arch. According to Finn, pulpectomy is defined as removal of all pulpal tissue from the coronal and radicular portion of tooth by Castagnolo et al. The metal should resorb as the root of primary teeth resorb, should not irritate periapical tissue, should not coagulate at any organic remnant in the canal, should be able to adequately disinfect and seal the canal, should be non-toxic, should not dissolve in oral fluids. If surplus metal has been filled in the periapical area, then it should be easily resolved. Proper consistency on mixing. It should not discolor the tooth, should be radio opaque, should be easily retrievable, should be harmless to adjacent tooth bud. In primary, zinc oxide eugenol, calcium hydroxide iodoform, permanent teeth, gutta percha, silver cone, stainless steel file method. Commercially products available: Vacop paste, which content of parachlorophenol, camphor phenol, Vitapex, Metapex. Contents of Vitapex, Metapex are calcium hydroxide, iodoform, oily additives, moisto paste, zinc oxide, iodoform, thymol, chlorophenol, lanolin. KRI paste. Compositions of KRI paste are iodoform, camphor, parachlorophenol, menthol in different concentration. Endoflace, barium sulfate, calcium hydroxide, iodoform, zinc oxide, eugenol. Oxide eugenol. It is the most frequently used obturating material. The filling material of choice is zinc oxide without a catalyst. Lack of catalyst gives adequate working time for filling the canal. Root canal filling material for primary teeth are zinc oxide, eugenol, calcium hydroxide, and iodoform paste. Both zinc oxide eugenol and Metapex and Vitapex have shown encouraging results. Study have reported that zinc oxide eugenol sets into the harder cement that resists resorption when extruded beyond the apex. Investigation by many et al. Reported 60% of overfilled canals show over-retained zinc oxide eugenol at 6-month follow-up. Flats et al. 1964 reported 20% of permanent teeth showed a deflection in the case of overfilling of canal with zinc oxide eugenol. Aaron Squen and Munuz Zebul 1975 reported that the zinc oxide eugenol irritates the periapical tissue of the rats and may produce necrosis of bone and cementum. Or years to resolve Grossman 1974, Woods 1984, Jewell and Wrong 1982 reported that premolar eruption was arrested due to toxic effect of ZOE. According to Reddy et al. 1985, lack of ZOE's antibacterial property may aggravate residual infection of root canal instead of prompting healing of infected tissue. Cole et al. 1992 reported it has no significantly effect on exfoliation of primary teeth in any case of the case. Working et al. In their study reported ZOE when mixed with other root canal filling material like calcium hydroxide and iodoform has good antibacterial effect and resorption capability as when used alone. In 1985, Cole reported that zinc oxide eugenol altered the path of eruption of succedaneous tooth. Wright, Cage in 1994 did a study on comparison and antibacterial effect of ZOE and KRI paste. Results suggested that ZOE has better antimicrobial activity than KRI paste. It had a lower cytotoxicity. 1998, in their study, reported that gross own filling was related to failure of pulpectomy with ZOE. According to Seduan et al. 2000, tooth overfilled with ZOE and those filled up up to the apex did not show resorption as compared to those which are filled 1 mm or short of apex. Holland et al. 2001 reported that 100% of tooth filled to the apex with the KRA paste and 80% of those filled with the residue were successful and not statistically different. Was observed when the teeth were underfilled with residue or KRA paste. Overfilling of canal, however, result in a much higher success rate of KRI 75% than residue 41%, which was statistically significant difference. It is of residue easily available. It is radiopaque metal, cheaper, and effective antimicrobial, as less cytotoxic in direct or indirect contact, good plasticity, insoluble in tissue fluids. Excessive filling led to mild foreign body reactions. Mursbal et al. Found Zedui cement has highly irritating to periopacal tissue and cause necrosis of bone and cementum. Rate of resorption does not coincide with the rate of resorption of roots. A little slow. Adrian reported that Zedui retained material alter the path of eruption of succedaneous teeth in 20% of cases. However, it has been showed that optimally filled and overfilled canals show a statistically higher success rate compared to the underfilled root canals. It has been found that urinol is not only a cytotoxic but is neurotoxic also. It to be underfilled when the material is filled 2 mm short of radiographic apex. Lentular spiral, if chosen for the obturation, then it should be smaller by 2 mm size from the last H or K file used or 1 mm short of working length. Powder contains zinc oxide, stabilized resin, bismuth subcarbonate, and sodium borate and barium sulfate. Liquid contains eugenol. Note: at the time of placement of pH of cement is 7, which potentially make them as the least irritating of all dentin material. Powder containing of zinc oxide and liquid containing eugenol. Powder contains finely ground zinc oxide, which enhances flow of cement. It has been shown that 1 mm ZOE eugenol cement has a radio opacity corresponding to 4.5 mm of aluminum sheath, which is slightly lower than GP. Monobasic carboxylic acid, when mixed with zinc oxide eugenol, it renders it less soluble than regular zinc oxide cements. Consistency of paste when used for the filling should be 1 scoop powder is to 1 drop liquid. Consistency for the temporary filling zinc oxide eugenol cement should be 2 is to 1. Calcium hydroxide is a colorless crystal of white powder prepared by reacting calcium hydroxide with water, a process called slaking, or is also known as hydrated lime or slaked lime. When heated above 580 degrees Celsius, it dehydrates, forming the oxides. Hermann introduced calcium hydroxide in endodontic. In properties of calcium hydroxide, it is antibacterial, heals periapical lesions, resorbs easily, does not set into hard mass, no discoloration of teeth. In 1938, Tischer and Zander introduced the rationale that calcium hydroxide has ability to form reparative dentin. Seltzer and Benden identified the osteogenic potential of calcium hydroxide. Ten et al. Summarized the mineralizing effect of calcium hydroxide. Estrella et al. Summarized the antibacterial property of calcium hydroxide. Calcium hydroxide in the dentin bridge repair at exposure site. According to Saki and Pisanti, Atala and Norjan demonstrated that calcium ion from the capping metal were not involved in bridge formation. Stark and his colleagues, however, believed that the calcium ion from the blood circulation, which they have shown by presence of radio-labeled calcium ion. 57 reported that calcium hydroxide could inhibit macrophage function and reduces inflammatory reaction in periapical tissue or in pulp when it is used in pulpectomy or in DPC, direct pulp capping. Hydroxide divided into calcium and hydroxy ion. Calcium ion stimulate deposition of calcium, construct blood vessel that favors mineralization. At the same pathway, Ba- uh, hydroxyl ion is bactericidal, increases pH, hydrolysis, phosphate, phosphodiester, release phosphate ion, which favors mineralization. Calcium hydroxyl, base space and catalase space is contained. Base phase contain glycose salicylate, calcium sulfate, titanium dioxide, calcium succinate, or barium sulfate that provide radio opacity. Catalyst phase contain calcium hydroxide, zinc oxide, zinc stearate, ethyl toluene, sulfonamides, oily compounds act as a carrier. Action initially bactericidal, then bacteriostatic. Hydrolysis bacterial cell wall lipopolysaccharide, thus making them incapable of producing biological fat such as toxicity, pyrogenicity, and complement activation. Neutralizes bacterial endotoxins. Reduces anaerobic organism through carbon dioxide absorption. Procedure is an ideal pulp cap protection agent. If used beneath the acid containing basis cements, it neutralizes the acid due to its high alkalinity. Should be used in very thin layer over or near pulp exposure. Obliterating the canal space with calcium hydroxide during treatment may minimize the ingress of tissue fluid used as a nutrient by the microorganisms. Dentinal tubules neutralizing attack of inorganic acids and leaches products from the certain cements and filling metal. Promote healing and repair. Disadvantages. Pulp obliteration. Due to osteogenic potential, it is capable of inducing calcific metamorphosis, resulting in obliteration of pulp chamber and root canal. Absorption in primary teeth. Induces internal absorption in primary teeth. However, investigations have reported that mixture of calcium hydroxide and iodoform is easy to apply, resorb at a slightly faster rate than roots, has no toxic effect on the permanent successor, is radio opaque also. Accumulation of underdeposited mesenchymal cells leading to formation of odontoclasts. These odontoclasts then resorb the dentine. Although it has been documented that internal resorption occurred due to calcium hydroxide in primary teeth, it does not appear to be to the heart tissue. It is a major shortcoming of calcium hydroxide. This lead to inadequate seal against micro leakage. Furthermore, calcium hydroxide metal have been found to dissolve under restoration where micro leakage has occurred, resulting in bacterial access to pulp. Does not adhere to dentine and resin restoration. Castagnola and Urle in 1952 demonstrated that KRI paste got resolved with the root at the same rate, which was seen as success. It is bactericidal and to microorganisms in the root canals and loses only 20% of potency over a 10-year period. Moisto in 1967 introduced a mixture of zinc oxide, eugenol, and iodoform as a RC filling metal in the permanent teeth, but was used by Tager and Sarnet in 1984 in primary teeth. In 1987, found that KRA paste is a bactericidal in root canals, resolved from the apical tissue in 1 or 2 weeks, is apparently harmless to tooth germs. Is radio opaque, does not get to hard mass, and easily inserted and removed. Mass in 1989 found moisto paste to be successful in treating an infected primary posterior teeth. He reported that iodoform containing pastes are easily resolved from the periradical region and causes no foreign body reaction like zinc oxide eugenol. Reported that when iodoform and calcium hydroxide are combined, excellent clinical radiographic and histological results were obtained. Matt Suzuki in 1996 reported that iodoform improved antiseptic and radiographic effects. Reddy and Fernandez in 1996 found mastopase to be 100% successful, 93% should be bone regeneration with the complete healing of interradicular pathology and complete resorption of excess material. 19 evaluated the effectiveness of Vitapix, calcium hydroxide and iodoform and found that it is radio opaque, does not stick to hard mass, resolve from the apical tissue within 1 or 2 week, 1 week to 2 months apparently, harmless to permanent tooth germ and can be easily inserted and removed. Chawla in 2001 evaluated the effect of mixture of zinc oxide powder and calcium hydroxide paste and distilled water as a root canal filling metal. They found the metal resolved at the same rate as the root. Study using endoflash as a filling metal after 52 months overfilling lead to success rate of 58%, underfilling showed a success rate of 83%. The paste also get resolved extra radicularly. In a study conducted on 96 premolars for the clinical and radiographic evaluation of pulpectomy using zinc oxide, eugenol, iodoform, and calcium hydroxide, Iodoform, Vitapex, zinc oxide, and calcium hydroxide. Iodoform endoplasm in 72 children of age group 4 to 7 years. It was reported that success rate was 90.6% with Metapex, 84.7% with Arcifil, 95.1% with Endofil. Iodoform. It is a preparation of iodine obtained by action of chlorinated lime upon the alcoholic solution of iodide of potassium heated at 1040 degree Fahrenheit. The product being obtained of iodoform and iodate of lime. The iodoform has no irritant issue. It in a small dosage it leaves pain, disinfectant, having great influence on nervous system. It is Scaripase is highly resorbable bactericidal iodoform 80% composition of Scaripase are iodoform 80% parachlorophenol 2% camphor 5% menthol 1%. Fuchs et al. 2000 found that success rate of 80% with the Scaripase group versus 83% zinc oxide group. Overfills more success Scaripase 79%, zinc oxide renal 41%. The excess space will dissolve without causing any adverse of paste composition. Camphorated parachlorophenol 4 to 8%, eugenol, zinc oxide, diiodothymol, menthol crystals, silver powders. Parachlorophenols, antiseptic, dissolve albumin, and which can therefore progressively penetrate into the canaliculi of the tooth. Major disadvantage is its total resorption, which occurs both in periapical and coronal area of the tooth. Even in the most favorable cases, there is no longer any trace of paste in the previously filled canal. 1 year after filling of the canal has taken camphor to allay the pain arising from the near exposure of the pulp of the teeth. Also, the pain of sensitive dentine. Also, to arrest the hemorrhage and allay the pain of wound pulp of all. Anodyne, antispasmodic, antiseptic. Menthol has given satisfaction as an extreme remedy in facial neuralgia, odontologia, as an obtonder of sensitive dentine, and as a local anesthetic. Endoflash. Endoflash is a root canal sealer metal composed of zinc oxide, barium sulfate, iodoform, calcium hydroxide, eugenol, and chlorophenol. The one condition for the success of endoflash is prevention of micro leakage. A permanent restoration should be placed as soon as possible after clinical signs and symptoms of inflammation after inflammation are eliminated. These are the table showing comparison of different materials like Zedoi, Vitapex, Carapace. Chawla, Italy in 2008 performed endodontic treatment in 25 pulpally involved mandibular primitives in 4 to 9 years of age children. The root canals were obturated with new root canal filling metal consisting of a mixture of calcium hydroxide, zinc oxide, and 10% sodium fluoride solution. All cases were clinically and radiographically evaluated after 3 months and 6 months. It was observed that rate of resorption of this new root canal obturating metal was quite similar to rate of physiological root resorption in primary obturating metal. By Baunan in 1867, chemically Gutta purchased polyterpene, a polymer of isoprene or polyisoprene, specifically trans 1,4-polyisoprene. Gutta percha. Palaquem is a genus of tropical trees native to Southeast Asia. It is inelastic natural latex product from the sap of these trees, particularly from the species Palaquem gutta. Also, it is obtained from the tree Gutta percha, is white in color. By the addition of dyes, it may be turned to any color of the rainbow. For many years, it was dyed pink or red for endodontic use because that was a color for the of the pulp, which is replaced. Friedman and Associate Gutta percha contains 80 Gutta percha 18-22%, zinc oxide 59-76%, heavy metal 1 to 10%, waxes or resin 1 to 4%. Because of poor sealing ability of GP, regardless of technique, it must be combined with root canal cement or sealer to ensure proper filling or sealing of the root canals. Phase transition of trans polyisoprene. Gutta percha at room temperature is considered to be beta phase. In this stage, gutta percha is solid, compatible, elongated elongatable. When heated to 42 to 49 degrees Celsius, it undergoes a phase changes to alpha phase. In this phase, it is runny, tacky, sticky, non-compatible, non-elongatable. The third or gamma phase occurs when heating is raised to 56 to 62 degrees Celsius. The properties are similar to second. Significance of gutta percha. The metal expands when heated from beta to gamma or alpha phase from less than 1% to almost 3% when cooled down to the beta phase. A shrinkage takes place a similar percentile, but the degree of shrinkage almost always greater than degree of expansion and may differ by as much as 2%. That means gutta percha is heated above 40 to 44 degree and then inserted into prepared canal. A condensation procedure should be applied. Some method used to lessen the problem. Gutta percha is achievable as standardized gutta percha. They approximate the diameter and taper of root canal instruments available as primary cones number 15 to 140. Non-standardized gutta percha in lateral and vertical condensation. Incompressibility. Inertness, least reactive of all metal, conceptually less reactive than gold and silver, dimensionally stable. It is radio opaque, becomes plastic when warm, when heated above 40 to 42 to 49 degrees Celsius. Some changes occur in GP according to Markin and Schilder. After heating, GP could be packed with plugger and its mass increases in volume. As known solvent, the most common being chloroform or xylene. It may be dissolved completely by chloroform, allowing retreatment if required. Elongatable when fresh, brittle when old. Fresh gutta percha when stretched, elongatable. Old gutta percha break off when stretched, indicated that old GP would not be as a compact as fresh one on obturation. Placement easily sterilized prior to insertion and does not allow bacterial growth. Probably the least toxic and least irritating to periapical tissue of all root canal filling material. Length control. Inability to seal the canal apically unless it is combined with a root canal sealer or cement. It has got limited shelf life, become brittle with age. Semi-solid filling material for obturation. Gutta percha beta phase, compacted gutta percha, injection molded obtura 3, ultra film. Indication to use semi-solid filling material when the canal has irregular walls and has non-circular shape. Whenever the condensation technique is utilized, that requires a flattened preparation to size 30. In case where the lateral auxiliary canal is anticipated, multiple apical foramen presents. Whenever there is a strong possibility of occurrence of an overfilling, semi-solid metal are well tolerated by the tissue. In cases of internal resorption, in cases where apical surgery has to be performed. Techniques of use: warm GP technique, thermoplastic GP delivery system, compacted GP injection molded techniques, chemically plasticized gutta percha by Capercha and Chlor Percha. Silver cones of points. Introduced in the 1930s, it was pure silver molded in conical shape, was often used for obturation of very narrow canals in which GP was difficult to insert because of lack of stiffness of GP. Also, the technique was less time consuming. Did not require much of canal enlargement. In 1941, Jasper introduced silver wires, later called it silver point cones. Most silver cones contain small amount of other trace metal 0.1 to 0.2% such as copper, nickel along with silver. The addition to cohesion to silver cones most common clinical complication. Indication in mature teeth with small or well confined round tapered maxillary premolar with 2 to 3 canals, buccal roots of mature maxillary molars, mesial root of mandibular molars if they are straight, not indicated for filling anterior teeth. Single canal premolars are large single canals in molars. Filtration. Seltzer and colleagues have shown that if failed, they appear black when removed from the canals. Coho reported the case of localized argyria of buccal gingiva or dark blue pigmented tattoo surrounded by the gray hole. Gutierrez and his associates in Chile reported that corrosion in cones appeared due to canal irrigant. Advantage has more rigidity than gacha parcha, hence can be pushed into smaller and thin canals in which gutta percha is nearly impossible to insert. Indicated tooth, it has to be restored with post and core since it difficult in cutting the cone. Disadvantages: they corrode because of micro leakage. Proper apical seal is not obtained. Poor adaptation, difficult to retrieve. Lower success rate has been reported with silver cone as compared to GP. Stainless steel file method can be used to fill fine tortoise canal suggested by Sempec. They have been used instead of gutta percha. Can be inserted into canal with greater ease as compared to silver cones. File is stainless steel file is inserted into the canal, and once it is inserted, then the handle of the file is cut off with high speed burr 3 to 4 below the occlusal surface to allow a space for the restoration. Fox and colleagues have reported 6 to 7% failure rate for the root canal fit with this method. Tim Powell and associate found that silver cones or SS files, when used with the sealer for obturation, leaked less than GP and sealer in severely curved canals. Recent advancement: mineral trioxide aggregate. MTA was the first described by M. Torabinajad et al. In 1993 when it was used as a root canal and filling metal. It was approved by US Food and Drug Administration 1998. MTA is a powder that consists of fine hydrophilic properties particles that sets in presence of moistures. Hydration of the powder results in colloidal gel that solidifies to hard tissue structure. Is one brand ProRoot MTA. Composition: tricalcium silicate, dicalcium silicate, tricalcium aluminate, tetracalcium aluminoferrate, bismuth oxide, calcium sulfate dihydrate. Preparation of mixture MTA. Available in open single pouch. Use entire content of water ampule. Hydrate all the powder. Add 1 to 2 drops of soil water if too stiff. 5 minutes working time. 4 to 6 hours set time. Cover mixture with moist gauze paste to extend working time. Refrigeration. Durabinajad and Pitford histologic assured MTAs with amalgam have observed that complete layer of cementum is formed with MTAs, root and filling metal as compared to amalgam. Torabinajad and Talha evaluated the leakage ability of MTA and other metals like amalgam and intermediate restoration and reported the MTA leaks significantly less than other root canal filling metal. Dr. Ares and Torabinajad 1956 showed the effectiveness of MTA in focal closure communication between pulp chamber and underlying periradicular tissue. Torabinajad and Hung 1960 evaluated the cytotoxic effect of MTA and reported that it is potentially a biocompatible metal. Torabinajad and Veteran 1993 showed that MTA as a root and filling metal showed less leakage as compared to amalgam. Torabinajad and Ditford 1993 root MTA as an antimetal effect. Slick and Moon in 1998 evaluated the retention character of MTA. MTA displacement at 72 hours of placement significantly greater than 24 hours. With slight displacement at 72 hours, it re-demonstrated the ability of re-establish resistance to displacement from dental walls. Presence of moisture in perforation during the placement was advantage as it aided in retention. Rubinstein and Kelvin 1999 concluded from their study of MTA that it can be used successfully for the apexification, pulp capping, and reversible properties, repair of root perforation non-surgically and surgically. Middleman 2001 used MTA in place of omocresol in purpotomized pyramid tooth and found it to be suitable replacement material for omocresol. Esenhi et al. Compared MTA with calcium hydroxide when used as a pulp capping metal in human teeth and evaluated less inflammation, hyperemia, necrosis, and thicker dentine bridge with MTA than with calcium hydroxide. Mechanism of action: it stimulates cytotoxin release from the bone cells, that is, it actively promotes the formation of biological barrier, it promotes thicker dentinal bridge, produces less inflammation, pulpal necrosis as compared to calcium hydroxide. It produces better asepsis of lesion. It activates activates alkaline phosphate and also increases the activity of calcium dependent pyrophosphatase that achieving asepsis and initiating the process of bone healing. The sealing ability and biocompatibility of MTA has been attributed to the calcium ion revealed from the MTA, which react with the phosphate in synthetic tissue fluid yielding hydroxyapatite, which help in sealing. The crystal grow and file the microscopic space between the MTA and dental wall when MTA gradually dissolves. MTA induces cytological and functional changes in pulpal cells, resulting in formation of fibrodentin and reparative dentin at the surface of mechanically exposed dental pulp, properly used for pulp capping material. On tissue healing, the test cells were observed to have normal morphology and indeed they were observed to be growing in the intimate contact with the MTA, Koh et al. In 1998. Indications in pulpal procedure, pulp capping, pulpotomy, root and filling material, apexification, root perforation, furcal perforation, radicular perforation repair, surgical root repair, internal resorption procedure, MTA, moist pellets, apply the moist pellet, then temporary filling, complete RCT, permanent filling. See the pictures. Radicular, very radicular perforation repair. In case of the root and filling material. Clinical procedure with apply MTA, confirm with X-ray, moist pellets, apply moist pellets, 4 hours setting time, seal canal gatta parcha. Seal the canal with root and repair. Flap, osteotomy, root and resection, root and preparation, then control bleeding, then lack of moisture control makes MTA unmanageable. And repair. See the pictures. Place MTA with a small carrier, condense moist pellets, do not rinse. Internal absorption. Clinical procedure MTA, moist pellets, temperature filling, 1 week, permanent filling, check vitality every 3 to 6 months. Advantages. It does not require compaction, therefore, there are always less chances of extrusion of these metal periapically. It helps in one step obstruction of teeth with open apex because of its property to form an intermediate apical barrier. Setting of MTA is not affected with water or blood. MTA has proved beneficial to create an apical plug at the end of root canal system. MTA has got good antimicrobial effect. It has low solubility and has radiopacity more than that of rentin. Promote guided tissue regeneration of original tissue. It has found to regenerate periodontal ligament efficiently. It has property to adhere to tooth surface, allow for overgrowth of cementum and formation. Disadvantages: very long setting time, about 4 hours. It requires a wet medium for setting, has low compressive strength, hence cannot be placed in functional area. It dissolves in acidic environment. Metals such as saline and acidic solution affect the physical, chemical, and biological property of